So welcome back. We'll get started even though half the folks are still out walking around the beautiful sunshine.
Well, actually, we need to, there he is, okay.
So, we're talking here about reimbursement in healthcare and cost savings and cost offset. So why should we talk about workplace behavioral health as maybe a question you're raising? And I can tell you, first of all, from my 10 plus years working for health plans who in turn work with employer groups, they're very focused on workplace productivity because they realize chronic disease, both medical and behavioral, has a tremendous impact on their bottom line in terms of lost productivity via absenteeism, presenteeism, disability claims, a tremendous cost for employers. They're searching for solutions. I think employer groups tried for 15 plus years to use disease management to tackle this problem, and without much success because, as you might suspect, if you try and have even the best clinician with the best protocol calling someone at home from a cubicle and trying to change their health behaviors, that's a tall order. So we're excited about taking integrated behavioral health and using the same techniques to improve workplace productivity launched from primary care. And our next speaker, Mark Attridge, I had the pleasure of meeting him about a year ago. I went to a major EAP conference in Chicago and went to his all-day workshop on this topic. So you're getting a condensed version. And I encourage you, if you like what you hear today, track him down. He speaks several times throughout the year across the country on this topic in much longer, more detailed format. So please talk to him afterwards if you want to pursue that. Let me tell you about Mark. Hang on a second. He's a research consultant and independent practice as president of Attridge Consulting Company. He's authored more than 100 works on different topics related to workplace health, benefits and services, mental health addictions, communications, and psychology. He brings 12 years of experience working with the National Director and the National Data Cooperative with Watson Wyatt Worldwide and as Principal Manager of Applied Research at the Optum Division of United Health Services, United Health Group. So please join me in welcoming Mark Attridge.
Hello. Well, thanks for the introduction, Ron. It was nice to have you come to my training last year. Doing a similar training up in Ottawa in about a month. I'd like to talk to you today about an area that probably is more relevant to your customers and your constituents, perhaps, than your day-to-day clinical or management practice. And I have three main ideas that I want you to remember from this talk. And I have kind of an encyclopedia approach to this because I've been doing it a long time and I have a lot of resources, a lot of information. And so you're going to have a lot of stories, a lot of statistics, a lot of samples of studies. And the point isn't that you need to remember all of those or that they're that significant. The point is that we're at a cumulative phase now in our research in this field that we can talk very authoritatively about the workplace impact of behavioral health services. And so that success is something I really want you just to remember and walk away with. And you can go back and find the details later. But my goal with this is that you leave here 90 minutes from now saying, boy, I work in a kick-ass field. We're doing some really good things, and there's a huge payoff for it, much more than beyond just our own services and our own budgets. And more people in the business world, the consulting world, are starting to get hip to that same message. And so our field is growing in demand. And I've got lots of evidence of that. But there's three main stories I want you to learn about. One is that we have a cumulative amount of information about what is the workplace, how does it work, how does behavioral health play into that, in particular employee assistance programs. In Canada, they call them employee and family assistance programs. The second theme is improving workplace outcomes, particularly about being productive at work, presenteeism, and also absence from work, absenteeism, in addition to all of the healthcare claims and other kinds of outcomes that are potential. But what about the workplace specifically, at work outcomes? And I think that's actually the primary payoff for our field. And there's a bunch of studies that will show that. And then the third part of it is a conceptual model that I use and instruct people about, consult with companies who sell workplace services, sell work life, sell counseling in the US and Canada, somewhat in Europe now where it's an emerging field, of how do you make your business case? And there's a number of different ways to do that. There's, in fact, 4 different strategies, each one with its own very strong research basis. It just depends on what's your service mix and what are you sort of advocating as your primary service. So there's really 4 different kinds of ROIs that I'll be talking about. 4 paths to value. So first off, what do we mean about workplace and employee assistance programs? Well, one of the projects that introduced me to the Canadian landscape, which is kind of catching up to the U.S., is a big consulting company up there was asked by some clients who were starting to do some provincial policy consulting about what do we know, period, about workplace mental health. We know a lot about substance abuse, we know a lot about depression, but how does it impact and how does it show up in the workplace? And so we were commissioned to do a big review of this. That's the paper there. You can get it for free. Almost all these resources that I write are available for free from different foundations or different organizations. But we found some initial research that showed from 1990 to 2000 that the number of scientific academic kinds of papers, or white papers, gray papers in the professional literature had more than doubled, from 500 to almost 1,000. Since I did my own review and added to this, I found another 266 studies. Since then, I project there's about 50 a year that show up. So today, I'd say there's 1,500 plus academic or business kind of science papers. Now, when I was getting my graduate training years ago at University of Minnesota, we had probably 100, maybe 500. And so just the knowledge about where do we make an impact, where are we needed, has dramatically grown. And what's interesting is the messages are pretty consistent, whether it's in Australia, whether it's in the UK, whether it's in Canada, whether it's in different parts of the US. Even the work I did with Optum, which is a big nationwide provider, the kinds of profiles of people using behavioral health were pretty similar in the military, in the government, in corporate environments. So the dynamics of what we're doing are pretty solid. We have a lot of information to learn about that. Part of my job over the years has been telling business people about our story. And so I've started to notice that there are a number of major textbooks in occupational health, in human resources, in the kinds of places that purchasers read, or they're getting their training and their MBAs or their background, that didn't have the workplace hardly at all in there. And I was kind of shocked. And so I contacted a number of publishers, and because I speak a lot, some of them have contacted me. And so I started to write sort of overview chapters about our field that go into management textbooks, HR textbooks, to kind of wake up this whole purchaser audience who's trying to manage the health of the whole company, the whole organization, to think about the workplace behavioral health component. So we're starting to see major journals, major books that are kind of basic graduate textbooks having this message. The other audience are just business people themselves who aren't reading the textbooks. They're out there running their business every day, trying to manage their claims, manage their organization. I was hired by an EAP up in Canada, one of the top nationwide things, to do an annual report on what does the science say about delivering and addressing different kinds of common mental health services that affect the workplace. We did a series of reports. The first one actually was on work life and family. Then we did the blue report, which is on mental health and depression in the workplace. Did another report on addictions in the workplace. Did a third report on how does it take to get people back to work who have disability, have addictions, to return to work, and more importantly, stay at work dynamics. And so each of these reports you can get for free from this website. They're about 30-some pages. They have 4 components. What's the problem? What's the treatment? Does it work and save money? And what can I do as an organization? So all 4 reports have the same structure, same attitude to them, same amount of resources, case examples. And so they're kind of what I call knowledge transfer reports. So it's taking our kind of academic training you're getting right now, but putting it into business speak and the examples they can follow. And these have been distributed to thousands of businesses in Canada and the US. We also were asked, well, what should I look for in a behavioral health provider? How do I know if an on-site program is doing what it's supposed to do? Is it credible? Is it qualified? Is it accredited? What are the policies and procedures they're using? And so myself and about 10 other people in the field were asked to pull together sort of a master paper from the provider perspective of what is it to be a good EAP provider? So if I'm a buyer of this, what should I look for? What's my checklist? If I'm a consultant or a medical director or a HR director. And so this right now is a free report you can get from the ISNA organization website. And it's kind of a funny story in a way because there's all these people involved and what is the best practice, and we had to kind of argue about a lot of things. But once we got it done, we were so proud of it. And it's 62 pages with some references and 10 different chapters. It's fairly short, really, given the scope of the whole field. And we started to get this feedback about, boy, that's great, Mark, but Christ, I can't read 62 pages. I can barely get 10 minutes with my manager. He's not going to read this. And so then we wrote a whole series of, we broke each chapter into a short report. And so they called notes, EASNA notes. And so now the EASNA organization has a whole series of notes that are on different topics every year. But it started with breaking these into 3 to 5 page little chunks. So if you have a question about, well, what's it mean to be a quality provider? Or what's it mean to have outcomes? Or what's the ROI story? You can just give your manager or somebody that one little chapter that's very authoritative, written kind of by people in the whole field. So it's, again, sort of sharing the ideas of the field. We also recently, last year, got some first ever global funding specifically for the EAP field that wasn't from the governments. It was actually from a private foundation to study what's going on in the field in terms of best practices and delivery. And so I was involved with a whole bunch of people, and we did a very large study. 82 different vendors from the US and Canada, and about 10 from the UK and some other countries, told us about their entire book of business. How many staff they have, what are their training, how do they work, what are their customers, how often they use the service, what kinds of things they use about the service, what are the outcomes they use, and a whole bunch of opinions about what do they think is good and bad about the field. So a very comprehensive major study. It's actually such a big study that it was published as a special volume of a journal. So it's the whole fall volume of the main peer-reviewed journal in our field. And so that stuff you can get for free at that address there. It's a 100 and some page journal article. So, got a lot of information, a lot of resources, a lot of people in the field have been working on this for 10, 20, 30 years. Well, what does it tell us about behavioral health in the workplace? These are stats that you've probably been hearing yesterday and somewhat this morning from others. The burden of mental health and addictions is probably one of the highest burdens of all medical field areas, especially in terms of the reach of people. This is prevalence data from the US, but there's similar data from Canada and other countries. 1 in 3 people a lifetime, according to epidemiological data, have a diagnosable condition. Milder forms of that are probably higher. Of the people with mental health diagnosed conditions, roughly 1 in 4 employees in a year will have one of the most common prevalent kinds of psychiatric issues. Anxiety, depression, phobias. Phobias are actually probably at the top. People just don't get treatment for them. Panic, schizophrenia, suicide. Most of the recent information about mental health conditions shows that almost half of the people getting treatment for mental health conditions have some other mental health condition. You probably already know that. We also then look at mental health cases. Roughly a third of diagnosed mental health cases have claims data or other record data about having some sort of substance abuse or addiction. That's actually probably higher if you include all the behavioral health addictions, which are only starting to get widely recognized or screened for. Gambling or sex addiction or work addiction, all the other kinds of process addictions. What's more important in getting more attention from the medical community, at least in my working with health plans at United Healthcare, was they're starting to have great giant databases. I ran a database for Watson Wyatt, had 40-some employers in it, had over 2 million employee records. They spend over $120 million a year on healthcare. They're very curious about what's going on with the health population. Because of all the good drug record data and its population-wide data, they're starting to see that almost half of cases that they're tracking as high-cost Pareto cases have usually a psychiatric prescription. Anti-anxiety drug, antidepressant drug, multiple drugs. And our top 10 drug list every month that we would give employers, usually anywhere from 3 to sometimes 4 of those drugs were psychiatric drugs. So even if I know nothing about mental health or behavioral health, and I'm the medical director, or I'm the CFO, or I'm the HR director, and every month my consultants are giving me reports that say, of the top 10 things that we're spending money on, roughly a third of them are mental health. What are we doing to treat mental health? What are we doing to prevent mental health? Is becoming a very common question at the leadership level because of this kind of prevalence data. Now, there's a lot of information going on about, well, what can you do about it? And there's a lot of treatment evidence, primarily strong worldwide global evidence for basic mental health talk therapy as being one of the very effective in general. Some research on CBT perhaps being better for workplace populations which are more acute and short term. Medication treatment for more severe cases. In best case scenarios, most prescriptions or prescribed or best practices from different task forces are for medication and talk therapy. Most of the data shows that roughly 10% of eligible cases that meet that criteria get talk therapy in addition to getting drug therapy, especially in America. We're probably one of the highest medicated countries, although Canada is pretty high. Workplace brief counseling also has a lot of research behind its effectiveness. We'll talk about that. Prevention approaches, how do you get people to notice things when they're smaller scale? Workplace interventions, management programs. And, of course, the growing evidence for relapse and long-term care approaches to addictions. I did a project up in Canada recently in the province of Alberta, and they had a 3-year project that was a public-private partnership funded by a foundation who was very interested in addictions and in child development. And they brought in 100 of the leadership staff who worked for Alberta Health Services, people like you, the kind of jobs you're going to get or you have now, and said, what do the scientists say and the clinicians say is the best way to think about addictions? And it's, of course, a lifelong chronic care model. That's just how it works. It's not a short-term 30-day care approach. That doesn't work very well. And so they ended up actually, over the course of 3 years, changing their whole payment and reimbursement model in the province of Alberta to say you need to have a long-term minimum 5-year treatment plan. Minimum. That's now the standard as of last year in Alberta. That's an amazing, shining example of science leading policy instead of the other way around, as Darren was talking about, often happened. So there are some bright points where this evidence is starting to change some of the delivery systems because the therapy works. The problem is most of the people who need treatment, roughly a third or so, are considered to have diagnosable levels of symptoms each year, according to national surveys. Roughly only 10% of those go into behavioral health care treatment system. Some also go into EAP workplace. So that leaves an unmet need of roughly 2 or 3. 2/3 of them aren't getting care they need. And so this is a big potential problem for employers or for society that people have issues, aren't getting it. I think you all get that. So let me just back up a little bit. What do our priorities say about this? What would the public reaction be if other chronic health conditions, such as breast cancer, there's a lot of public sentiment toward that. I mean, NFL players are wearing pink gloves and pink shoes. That didn't used to happen. Think about that. Heart disease, all kinds of stuff. You get a box of Cheerios, now it has a little happy heart on it. Widespread public opinion for that. Diabetes, a lot of information about that. What if those conditions are so poorly attended to by their professional community, 2 of every 3 people affected sought no care at all? Yet, that's what happens today with our field. Why is that? Is it a political issue? Is it a financial issue? I don't know. But it's something I think we should change. And I'm glad you're all getting training in this because you can be part of that wave of change. One way this is being responded to very effectively in many cases is through workplace approaches. Because most of the people with these kind of conditions are working, either full-time or part-time. And so that's where they have an access opportunity to get benefits or get an introduction into the treatment system. Employee assistance programs in general started with a substance abuse focus in the 1930s and 40s. That's where they were first started. They had a labor shortage, and instead of firing all the people that were addicted, they said, well, we need to train them and get them back to work and stay in the workplace. Many years later, we're still doing that. They've expanded quite a bit, though, to dealing with marriage and family, dealing with work, dealing with work-life issues. Their main goal is to kind of keep people productive at work and to help them provide resources and counseling as needed. It's a short-term acute care kind of steerage model. Can I calm down what's going on now in my life or in my home or at work? Can I get back to work, and can I know how to treat this over the longer term? Can I find some resources? So it's kind of an assess and refer approach. They have 3 models of this. Some companies are big enough that they have their own counselors and staff inside the company that run the program. That's called the internal model. Most companies buy counseling or management from an external national vendor, and then they work with different counselors and social workers around the country to deliver the services as needed, kind of on demand, and some combination of that. Most EAP counseling, according to our big national study, about 80 to 90% of activity is about the individual. What's going on with the individual employee or their family. Some kind of talk therapy, some referral. They often do it now. In-person has been the model for many years. The past 15 years or so, we've seen a whole lot more telephone service. My company, Optum, was one of the first major telephone providers. We did a lot of research showing the efficacy and outcomes are pretty much the same as in-person treatment, although people self-select depending on what they like to use. There's now a lot of research on doing things with chat, with email, different kinds of video, internet, different technology tools. And most of the global research on that has been funded by Australia, by the UK, some in Canada, places that have rural health access issues, so they're paying to study these. Most of those studies show they work at equivalent levels for face-to-face counseling, using the same protocols, the same outcome tools, same diagnostic symptom tools. So most of the evidence is that these other technologies work actually quite well. And initially, therapists and people were like, well, I just don't believe that because I was trained in the face-to-face method. And so I've written a number of articles trying to say, well, go read the literature, figure this out. From a cost perspective, a lot of organizations are trying to augment their face-to-face therapy with some kind of distance tool. Now, all of you use distance education, so you're well aware that it's functioning and works just fine, has strengths and weaknesses. But they're applying that a lot to mental health delivery, and it's kind of an exciting area. The other area that EAPs are quite different from the behavioral health system is that they go into the workplace and they help with management consults. If a manager's having a problem with an employee or a team isn't working together very well or they had a merger in a department, they can do training and education. They also work directly if there's a crisis or a trauma event. Let's say there's a hurricane, or let's say there's a shooting at work, or let's say a domestic abuse situation happened and somebody from home came into the workplace and caused a scene. Let's say you're a convenience store or a bank and you get robbed every week. You just don't know which store and which bank. But you know they're going to have crises. And so they help people prepare for that and to respond to the sequelae afterward. So the behavioral health side of EAP is kind of a dual level thing. About 90% of it's individual in the workplace or over the phone or maybe over a chat. But a lot of it, the most high value really is the stuff in the workplace, working with management, working on a preventative level, coaching people how to think about mental health issues. Well, EAP, having that dual concept, is something that people like. Businesses, by definition, spend money on things they see value in. They stop funding, they defund things they don't think are valuable. This chart shows in 1985, different national surveys of businesses and organizations, how many had any kind of EAP provider. Roughly 1 in 3. A decade later, 1995, it's about the same. When HMO started taking off in the late 1990s, early 2000s, many of them started adding counseling as an additional benefit to the health plans. This started to cause a huge boom in managed care and an access for employers to buy mental health counseling and at least get started on that path. Most recent surveys by Mercer Consulting, which used a random sample methodology of businesses all over the U.S., showed 82% now have some kind of EAP. That's remarkable success. So in terms of businesses thinking about counseling, they already all think about it. Most of them are paying for it, whether they individually use it or not. As a management decision, they're already buying into behavioral health. But it's limited to those who have a budget for it. The really large jumbo companies, 5,000 or more employees, 93% in the U.S. have it. The other large companies, 500 employees or not, 87% have it. Where it's missing the market is actually where most of Americans work, and that's for small employers. I read some stat that over 90% of Americans work for companies that have less than 50 people, which are exempt from most of the labor laws and labor regulation things, ACA requirements and stuff. But anyway, put that aside, the bigger clients, bigger organizations, governments, as well as private sector, roughly 9 out of 10 have workplace counseling access. The question is if they use it. So the basic business case of, well, do we need counseling for the workplace? Do we need to prevent trauma potential situations? Do we need to have a management tool to help with behavioral health dynamics of their workforce? Most businesses already say, sure, and I'll pay for that. So we're already having an ROI, so to speak. Well, what does this budget that they're paying for EAPs deliver? Well, our national survey, the first time we've ever had this data that wasn't a case study of one provider, averaged across many, many different providers, 80-some providers. I did some math on it to say, well, if I have a company that has 1,000 employees, what's my utilization profile of this counseling service going to look like? Just what's the basic math on this? So it's pretty small. 45 out of 1,000 people, an employer will get an EAP. 4 or 5%. 4 or 5 out of 100. Some of those are going to be family. 9 of those 45 are a spouse, maybe an adolescent, usually a spouse. 8 of those 45 cases are going to get referred on for more care. So they're going to get referred for marital counseling, get referred for stress management, get referred to a psychiatrist for medication maybe, to get assessed for depression perhaps. Maybe they get assessed for substance abuse. 1 to 5% of most EAP caseloads are substance abuse. 1 to 5%. Maybe 10% if they're a good screener EAP. So if you get 45 cases to start with, roughly 1 in 10 of those is alcohol or addiction related, at least that they screen and find for it. Most of these programs aren't really addressing addiction anymore. They're training on it, they do it, but people don't go through the EAP to find substance abuse and addiction. Although that was the founding hallmark of the field, and most places are very good at it. people in the workplace don't want to let their employers know that they may have addiction issues. Now, all EAPs are anonymous, and you can call up and you can use them and get an appointment. You have to say who you are. You just have to know that you're an employee and have access to that service. They really don't care if you work there or not. They don't even care if you're a spouse or family member. They'll still help you. Yet the perception is, because it's a workplace benefit, that somehow my workplace is going to find out. And if I have these issues that are things that I don't want people to know about, then I'm just not going to use the EAP. So the biggest problem with the success of EAP not being more used is really the public perception of it's not breast cancer. I can go and talk about breast cancer. We ran a nurse line service. These nurses work 24 hours a day. Call them up, talk about anything. Within about 20 seconds, they'll be telling you the most gory details about, all kinds of stuff in their life. They don't know who it is. It's just a nurse on the phone. You ask them about, what's your depression? Are you anxious about that? They shut down. That's a different phone call. They don't want to talk about that. They don't want to talk about, the drinking, and that's why it's exacerbating that. They don't want to talk about the abuse that's going on in the home. It's a whole different dynamic to get into all these things. Yet, this is the typical profile. There's also management consultations that go on, some kind of trainings in the workplace. There's 1 to 2 crisis events that happen that they go respond to, very visible public events at a company that really demonstrate the value of counseling and trauma response. Some trainings about the EAP. So a whole mixture of stuff that's going on in most companies. On the counseling side, what actually happens is people see a counselor for 2 or 3 sessions on average, or they talk to them or they chat with them, but mostly it's talking, either face-to-face or over the phone. Now, this is stats from 45 different national vendors, some regional vendors. This is their average number of sessions per clinical case for their entire book of business, all customers, all markets for a whole year. Some EAPs average just over 1 visit per person. That's very brief counseling. Some average 4 or 5. Those tend to be the regional, smaller EAPs, some of the EAPs in Canada where they kind of have a more treatment-based model because they don't have much treatment in the community like we have in the U.S. But most are 2 to 3 sessions. So what happens in those 2 to 3 sessions? That's good enough. Well, the main thing is I get assessed, and I get calmed down, and I can figure out what my options are, and I know where to go. Most EAPs provide 2 to 5 direct resource options, most of them for free or benefit covered, of what to do next. So I can go into benefits, I can go into the community, I can use the other resources that are online, and I can go back and get some coaching from the counselor to help with this. But it's not that I'm getting ongoing depression counseling. I'm not getting addiction counseling. This is sort of, again, calming and steerage. This is what they're really good at. Some EAPs say, I don't even do clinical work. Don't put that brand on me. I'm a licensed clinician, but we do a different thing in the workplace. It's not our goal isn't to provide sort of treatment and cure, so to speak. It's to provide immediate attention to an acute problem. Now, most people don't make appointments to see the EAP. Almost all of it is on demand. So if I have something happen to me that I have the courage enough to reach out and say, this is a mental health issue, this is a family issue, I'm having trouble with my workplace, and if I see my boss again, I'm just going to do X. I can't take it anymore. That's when these services get used. And so they're incredibly important in that they're self-sustained, they're self-initiated, and people want to use them right now. Most of them are 24-hour access. A high proportion of services come on the weekends and the evenings, and other services aren't open and not available. And so this is sort of a relief valve for companies and people that are stressed out and have issues, or it's at a tipping point where they just have to do something. And often just knowing what to do is itself tremendous value. So even though these are brief issues, they come at really critical moments. It's kind of like if you're thinking about the ER and how long you wait once you get there. That timing is really critical. With this kind of workplace mental health, the fact that even people use it for 1 session is pretty dramatic, given how much mental health and addictions are stigmatized. The fact that they reach out at all. And many of these, roughly 15-20%, come from referrals within the company. Their manager says, do this. A colleague says, I use this, you should use it. I used this last year with my family, it worked out good for me, you should use it. So what happens when they use it? Well, according to our huge national database of results, reflecting over 130,000 individual users in the year 2011, 94% of the individual people, mostly employees, say this is helpful to me. It helped with my issue of why I called. Now, again, that goal isn't really huge. It's I want to calm down, I want to get some steerage, I want to know where to go, I want to feel like I'm back in control. And I have some options here. And interestingly enough, given the situation, almost 9 out of 10 of them say they improved in whatever the issue was that they were calling about. And they call about, 20 or 30 different clinical categories as the most EAPs have. So quite a range of issues they have to respond to and provide resources for. It's not specialized. It's very broad. So this is tremendous data for ROI right here. As we were hearing earlier today, just the clinical effectiveness alone is where most research stops in the medical field. Of all the medical journals, probably 1% are about value and outcomes, other than clinical efficacy. So this is good enough for most people. So when people are doing this professionally as academics, and they want to look at all this data and say, well, is this good information? Is these good studies? The most recent review I could find, this is their conclusion. Workplace counseling is generally effective, alleviating symptoms of anxiety, stress, depression, majority of workplace clients. This actually was a review of 10 different studies over in the UK. But those are ones in the US. So this first part of what do we know about the workplace? What's the pattern of workplace health? How is it used? What happens to the people who use the service? We've had about 25 years that have gone on in this field, generated a large amount of applied research, many scientific reviews of that work, knowledge style transfer reports. So getting this message out to business is happening. The kinds of personal and organizational problems that involve behavioral health disorders are significant burdens on society and on business. That's why most of them are paying to have an EAP. So most employers care enough about it to have an EAP in place, and they're trying to recognize the broader comorbid issues and how it's affecting their high-cost cases as well. Trying to get the EAP to be used more is the goal. It's not a question of should I have one. It's why can't we use it more? That's the main question they have. So EAPs have become a successful and effective resource for working populations, company-sponsored benefits available to most employers in the U.S. Now, most people, when they use these services, pay nothing. It's a completely free service. The only person who's paying anything here is the company that's paying to sponsor the benefit. So, done with part one. Questions, reactions? Sure.
Could you go back to the slide that had the percentage on it about people continuing on, was that 18%? That, right there. The 1 in 5 cases that referred out, is it referred out after completing 5 sessions? Okay.
No, it's a good question.
Referred out at any time in that 5 sessions span?
I'll just re-say it. The question was, why are being cases referred out and at what point in the counseling number of sessions that typically happen? Generally, about 1 in 5 cases get referred on for more care. This often happens after the first case or the second case because they'll do like an expert assessment or they'll do some kind of assessment. These clinicians that do this are experts at this. I mean, they do it all the time. They see a lot of patients, a lot of clients. They know what the parameters are usually. And the people want to talk about it because they're in some acute situation that they want to get help. And so what they usually figure out after 1 or 2 sessions is that, well, there are other benefits that are more specialized that are going to be more helpful to you. And so often it's referred out fairly soon. That's partly why it drives down these number of session rates, because other people take over.
Do you also, the follow-up question I have is, do you see a trend with companies that do EAP coordinating or not? So 2 questions. Companies that do EAP coordinating to make sure if you have a case like that the EAP counselor may also be a counselor that is part of the managed care benefits that would kick up after that. And do you see
like
that? And then do you see it like a self-referral so they could continue on and not have to go, oh, well, I don't take your managed care, but I do take the EAP. And do you also see a trend on the business side of encouraging employees to do that? Use your EAP benefits and match up with somebody that you could just roll and continue with.
Yeah, pretty much a yes to all 3 of those. Our big vendor survey asked people, does your policy as a company, as a professional vendor, allow you to have case continuation with the same counselor? More than half said yes. And almost all the ones just said no, which says it depends on my contract. So it depends if they're really accessible or not. Because a lot of these are telephonic EAP, and some really not accessible even. So it depends on the model. But the goal, of course, is to have a lot of follow-up. The problem is most EAPs are paid almost nothing to do this great service, roughly $25 a year per person. So the staffing to do a lot of follow-up is pretty sparse. Unless you're an internal EAP and you really have a mandate to do that, most of the big national vendors don't do enough what I would consider high-quality follow-up case management, unless they specifically partner with a program where they're co-managing it, like with addiction or with chronic care. Then it goes really well. But often they sell that as like a separate package of services so they can at least do the follow-up. Normally about 10% are followed up just on random to make sure everything works. But they generally call up to say, did you make your connection? Is this working? Are you using the service? And then they don't do any sort of therapy co-management after that.
Are there issues of privacy or bleeding through from employer personnel records, or any issues with lack of utilization because of employees' fear of privacy issues or having an effect on their job?
Oh, great question. Well, the lack of privacy is, I think, two answers. One is, in reality, there's pretty much complete privacy, because that's how all EAPs are trained, that's how they're set up, it's how the data management system happens. There are some cases where it's a management referral, where they know that so-and-so referred someone for treatment. So that's cases where they would know about it. But in general, most of the use is self-initiated, and the records are kept somewhere else with an outside company. I think the perception that the company is going to find out about my use of the service, though, is very widespread. Even though it's not true, I think that dampens the use of the service dramatically. And I don't know really how you get around that, other than, some companies that were skeptical of that back when I was working for an EAP, they'd say, well, do a test call. Call up, make an appointment. What do they ask for? They don't want your name. They don't want these things. You're not going to be identified. Just test it if you're concerned. But I think it's the perception about it that's an issue. You had a question.
Yeah, I'm just wondering if you can tell me about the
Oh, wait a sec. Use the mic.
Thanks. I'm wondering if you can tell us about the disciplines and training of the counselors.
Oh, fantastic question. Again, we asked about that on our big survey, so we have some data on it. But most of the people that do workplace counseling are private practitioners that work in the community and have a social work degree. The other, probably 30%, are people with a master's degree. People with a PhD are probably less than 5%. And very few that are psychiatry or other things. It's mainly social work and psychology. The people who run the EAP, if I'm an internal EAP director, I'm either one of those two occupations, or I may be a medical director who also does it. There is individual certification from a clinical management perspective called the CEAP, Certified Employee Assistance Professional, that is generally a 2 or 3 year part-time effort to learn all the things to qualify, and then you know kind of about how EAPs are supposed to work. That's considered sort of the premier designation.
And the follow-up question is, are contracting or billing done on the utilization basis, or is it just a blanket rate per year for the organization?
Well, it's 3 rates. The most common is a per employee per member, or per member per month, or per year, some sort of capitated, I'm going to guesstimate you're going to use it at 5%, and here's what my operational costs are, and here's my little profit on top, and that's what our budget is. And we hope people use it more or less, so it kind of hits that level. The other, about a third of it, is contract fee for service. So I want to see a certain amount of trainings. I'm expecting a certain amount of crisis events. I'm expecting a certain utilization of counseling, and I'm going to prepay for that amount. And if there's anything beyond that, I'm going to buy it a la carte. So if I want a training, I'll pay you $1,500 for that. Or if there's a certain event, we'll pay for that. So some kind of do it both ways. They pay for the basics and then are willing to pay more if it's extra. Great questions. We need the microphone over here, please.
Okay, so I moved from Gillette, Wyoming to Colorado, and in Gillette there's a huge mining industry. Mm-hmm. Also in Gillette there is a huge alcohol problem. Mm-hmm. Now, I worked for a small private practice that was mental health, and we did get contacted by EAPs, and these numbers look like they're great, that it's very effective. However, the EAPs were willing to reimburse at a much lower rate than Medicaid for our services. I think it was like $50-some.
Yeah, average is probably 50 or 60.
Okay. And so, but from what you're describing, it sounds like they want it to be very brief and intermittent, whereas the provider who is being contacted is thinking of your traditional 50-minute hour. So how would you suggest trying to bridge that?
Well, it kind of just more full disclosure about what happens in sessions, and it kind of depends. Usually it relates to the clinical severity of the case and what do they need and what they want to go through. A lot of times the workplace people don't want the full session. They want to have certain pieces of it and keep using it as needed. I think the addictions kind of aspect is a whole separate field. And in Canada, where they have big mining operations, they have huge addiction needs, they actually have a whole separate EAP sort of product where they have dedicated counselors who are experienced in that, who are expected to have a lot more contact and much more frequent clinical actual intervention or clinical treatment around it, as opposed to typical EAP, which would be more about resource finding, making sure you're not in trouble, in terms of safety or things like that around some of these issues. So often they would sort of buy up, so to speak, to a more more treatment-oriented product. And some places specify I want to have 4, 5, 6, 8 sessions. All of the research shows on average no contracts meet that. There are always 2 or 3 sessions less. But some employers say, I want to give people the option of having up to 4 to 6 or 8 sessions paid for. Most people won't really use it, though, because their situation gets figured out sooner or they need more intensive care. Well, great questions. You talk a little bit about kind of the major outcome of all of this stuff. I know you're mainly clinically oriented or running clinical or medical co-managed programs. Most of the people who buy workplace health don't necessarily care about those costs and outcomes, to be honest. They have a health plan that does that. They have a medical benefit. That's a whole other area. What they want to know is, are people at work going to be working well, and are they going to show up at work if they have these issues? So this is a big, nice white paper I found that's going to be a PDF on the website from the conference here about presenteeism. There's now so much research on it. It has a whole white paper, literature review, academic peer-reviewed study. He defined it as attending work while ill. Absenteeism is just not showing up at all, ill or not. You're just not there. Doesn't matter what the cause is. You're not there. So companies that are interested in this are a very interesting pack. And I've spoken at all these different conferences and been people on these boards over the years. The National Business Group on Health is mainly an advocacy group for employers who want to have better health care for their employees because they pay for it in the U.S. Only country in the G8 that does, but we do, so they want to figure it out. So they published major guides to employee assistance, guide to behavioral health, guide to substance abuse. So they're sort of educating employers about how to make your healthcare system work better, how to make these services work better. The Institute for Health and Productivity Management is a fascinating group. It's been about 10 years. My first conference I went to, I was on the founding board of it. I think we had like 43 people at it. Now they cap it at 1,000, and they have 2 meetings a year. And they have meetings in Canada, and they have meetings in London, they have meetings in 2 or 3 other global countries every year. The business perspective on my success as an employer and making money is tied to the human capital and their success is so obvious that you would think every employer is interested. Not that many are. The ones who are, though, are really advanced about it. And they go to these meetings, and they go to these measurement tools, and they go to these case studies from Dow Chemical and big companies that have all great data, and they're learning about this like crazy. It's just fascinating. It's a great place to go. So as an organization to follow, you should be a follower to IHPM because they just have great research. It's all clinical-based, research-based, real data for the real businesses. The other place that does a lot of interesting work is called Integrated Benefits Institute. This is Tom Perry's group out of San Francisco. They have almost 200 employers who pay a small fee to crunch all their data on healthcare, pharmacy, medical, and disability. They don't have much EAP data. A lot of disability data. So what they do is they say, what's your total spend? Not just pharmacy, not just medical, not just outpatient, not just inpatient, not just mental health, not just drugs for mental health, but all of it. Let's just stir it all up and see what your real cost is as an employer. Very appealing. They've done a lot of research over the years that I'm going to talk about in a minute that shows mental health and the drivers of that are a huge driver of total cost. So the employers that are starting to crunch all their data, which is great, are getting this really clear message about we need to have a total person perspective because they see it in all this cost data. What they've added to this mix at IBI is that over 200 employers are starting to use on an annual basis with every employee once a year, in addition to their health risk appraisal survey that asks about, did you exercise, are you safe, are you eating fruits and vegetables, they ask depression screener items. They're asking addiction screener items. They're starting to ask about mental health issues. They're also asking about presenteeism and absenteeism. Some really nice measures for that. So we've got 200 employers now that are having these super data sets that have real costs, and they have employer perceptions of my performance at work and my self-risks. And so they're really starting to understand what the drivers are, at least from following data, not leading data, what's going on at their companies. And they do it for like minimal cost. They're trying to get more companies to do this. Global Chestnut Partners is a company that does a lot of worldwide EAP work. They're in Russia, they're in Latin America, they're in Europe, they're in the US, and they do a lot of measurement on the clinical side that's very strong. So they're bringing a lot of clinical expertise to EAP as it's a startup in other countries. They have a number of tools that they market. These are the tools that now many corporations are starting to use and pay for every day. That goes on probably once a year as an annual survey, or it's a specialty survey that they're probably going to say, so when you're seeing your counseling patients, what presenteeism scale are you using? What's your absence tool? because a lot of health plans, a lot of specialty organizations are using these. Health and Productivity Questionnaire from Ron Kessler and Harvard and the World Health Organization, that's almost 10 years old now. Worldwide database on it. The Stanford Presenteeism Scale, Work Limitations Questionnaire. The MPAC one, which is by the National Behavioral Group Health, that group on the top relates to the MPAC measures. Chestnut's tool for EAP services. Whole bunch of brief items. Almost half of the major EAPs that we surveyed use a standardized measure every day, every client, with their tools at least 2 years ago. So the field is progressing to start getting some standard data. I'm not going to have you read all these, but this is the Harvard tool of what does it mean to have presenteeism. Was your performance higher than most workers? Was your performance lower than most workers? How often did you find yourself not working as carefully as you should? And so there's different kind of ways that they can measure it by asking questions about are you being productive and performing at work. What's fascinating about this research is that when you stack it up with disability, with absence data, with your cost for medical, your cost for pharmacy, all the cost buckets that these super databases have, and you add this self-reflective, self-report about those kind of presenteeism items I just talked about, or other versions of that, what you find is this is a quote from a study from Staywell Health Management, back in my hometown, probably one of the premier health risk appraisal people in the whole world. They have a bunch of PhDs researching all their stuff. They publish their stuff for free, which is amazing. Most vendors won't share their data. This is a study over many years of all their customers. 772,000 people took their health risk appraisal tool that had presenteeism, absence, self-reported items in there. Very brief items. Or 106 different employers in the U.S. When they crunched all that data to answer the question of what's driving our costs, they find that the stress and depression were the strongest contributors to lost productivity. Not 10th on the list, not 5th on the number 1. Consistent to related research indicates mental health issues are stronger drivers of medical expenditures than more commonly attributed cost burden related to cardiovascular, stress and diet and cholesterol and all the stuff that caused the whole health risk appraisal industry to even be an industry. Now that industry has started to add behavioral health to it, their whole product line has got to change. Because every time they present to a customer and they show these health risk appraisal results, what comes out on top is not cholesterol. That's a long-term life predictor. Costs 20 years from now. Costs right now for my employer are productivity. Costs this week. You don't have to wait 2 to 5 years. As Darren was saying, to get a good outcome for substance abuse, you can find this next week. And so this is the vendors who are selling primarily non-behavioral health services, producing this kind of data, publishing it in academic peer-reviewed journals. This is astounding. I would have loved to have this back when I was in grad school 20 years ago. This would have been great. It would have set me on a whole different course of stuff. So when you look at about 10 different major super database studies, companies that have all this amazing data that the U.S. is so great at, here's what you find. When you add up the studies for health and disability and returning to work and being off work, major problem, major costs, 1% to 2% of employees have this a year. That's a big deal for that 1 or 2%. When you look at absence and turnover, that can be a very big deal, especially turnover if it's $50,000 or so per year per employee. Depending on your market, turnover happens a lot, maybe it doesn't happen much. Those are all independently very good areas to look at. But if you do a total number crunch, and I'm a business person, I want to protect my whole company. The big answer is, it's not about those other things that are high cost for a small group of people. It's about the low cost for almost everybody, being a little bit less productive for half of my workforce. That adds up to a giant amount of money. And they have metrics for that and tools, and now they have self-report ways to assess how prevalent that's going on in my company. These are all major world-class researchers with real employer case data sets or real vendor data sets. These are not things that are kind of wishy-washy studies. These are pretty major studies in the last decade. Productivity is about 70% of the total cost burden. So the potential to have cost savings from treatment interventions is where? If you're an employer, what kind of services do you want to see in your suite of everything you're trying to deal with? You're going to want to see things that deal with productivity, right? So that's a dilemma. How do you deal with the productivity cost burden? It doesn't show up in my claims data, but when I do these bigger studies, I see it really clearly. EAP services are one way of trying to address some of these issues. Now, we had data from quite a few vendors, but not as many as the full data set. Some weren't measuring this reliably, which is shocking to me. But the major outcome for most people that go through this short-term brief counseling for acute issues is that about 3 or 4 of them say my productivity was a deficit and now it's better. Over 2/3 say their absenteeism improved a little bit. So these stats by themselves are pretty much good enough to also sell EAP on top of the widespread clinical effectiveness data. People get helped, and then it helps them do better in their work. Well, the reason that they have better performance, better absence, is because they've improved in health and well-being. It's because they've improved in their stress. It's because they can function better at home and at work. This is a study I did, 2001. 6,000 nationwide cases of both EAP and NurseLine, asking them the same questions every day when they come through the phone service or the face-to-face service, same exact measures, all customers nationwide. We find out that these things are highly positively correlated, which of course they are. But this kind of data is very powerful to business people to say, well, show me your data. This is the kind of evidence that links clinical improvement with work improvement. I didn't have the luxury of using the presenteeism scales that all the academics have developed that have all this careful research on it, because my business people said, I don't have time for you to do all that measurement every case, every day. We need to have some short. So we created a one-item scale, which is now used by actually a lot of the bigger scales that can boil down to one item on productivity or absence. How would you rate your overall performance the days you worked during the past 4 weeks? Again, it's a short-term window. Usually 1 month is the outcome period for all these things. This scale and the study I did, nationwide random sample phone study, with the full HPQ tool was correlated very strongly. So even one question correlates pretty well with all the academic tools. So you could add this one question to your outcome pre-post surveys tomorrow and have a really strong story that costs almost nothing to collect. And everybody answers this. Almost nobody refuses to answer it. It's pretty straightforward. Well, we did a study of this back when I was a research director at a big EAP. We had over 26,000 people fill this out over a number of years, nationwide, Medicare, government, employer, all kinds of different markets. Among the 70 cases that had an improvement, about 1 in 3 came in the door not having productivity issues. It was more something else that wasn't really that acute. The average is about a 4 or 5 on the 1 to 10 scale. So they're not functioning very well. I don't know if this, here. So that's half of the time they're not doing well. It's quite a deficit. That's why it's acute enough that I have the courage to pick up the phone, to go into the office, and I have to deal with this. Because my work is really not working. I'm not doing well. I'm not functioning. I was last week. I'm not today. This is the reason they use the EAP. Because they're going to get fired. They're going to get laid off. Their team is pissed off at them. They're not being able to contribute. So this makes sense. What's interesting is that after, 2, 3 sessions, 4 sessions maybe, look at the rebound. It's giant. I think that's a big result. It's a great result. And this is because of course, the clinical intervention. They're not talking about why you're productive at work and stuff. It's not the counselor discussion. The counselor discussion is about the clinical issue. Maybe it's about work, but it's not usually about work. Now here's the nationwide national norm with the exact same question of people who don't use the EAP. They're not 100%, they're not a 10. So most of you today, how hard am I working? I'm a 9, 8, maybe I'm a 10. So it's pretty much on par with what most employees are. Not quite back up to the high level, but it rebounds pretty strongly. So the question is, we need to average this out as a business person to say, well, everybody who uses an EAP, I want to know a result for everybody. So you kind of attenuate the result and average it across everybody. This says there's about a rebound of 29% in average work performance for most people who use the EAP. Average across all the clients. Well, I was curious about, I have my own database that I've used, but I've looked at a bunch of other research studies. Now they're starting to publish more of this kind of data. And you're seeing big samples, multiple vendors, all have around roughly 20-some, 30% improvements in productivity on average for their entire book of business, all customers for the whole year. Very robust number, every one of those data points. So the typical effect for workplace counseling for acute issues is there's about a 30% improvement in productivity. Well, so what? What does that mean? Well, if I work full-time or almost full-time, it's roughly 40 hours a week. Say a month is, 4 times that, 160 hours a week. 31% initial loss. If I've rebounded, that means that my loss was at that level when I started. It was even lower, right, when I started. So the burden of this is roughly 50 hours in a month, just for 1 month. Maybe it's going on for longer, who knows? Probably not, though. It's an acute issue that they actually took action on. So how do you determine, well, what's an hour of work worth? Most people say I get paid $20 an hour, it's worth $20. Business people don't think that way at all. If you make $20 and I pay you $20, you're a worthless employee. Why should I have you? Well, seriously, you got to produce a lot more than what I'm paying you to be a useful employee. A multiplier of that at least. And I need to include the benefits and the compensation and everything else I'm paying you for that makes you show up at work. Try hard for me. So most of these studies don't do this, but this is something I do and I recommend in my consulting, is to say, take the full value of your outcome. Don't just use $20 an hour. Take compensation, take a wage multiplier, 1 to 1.5 to 5. When we talked to Cisco company, they use a 5-to-1 multiplier. America Online was 3.5 to 1. And most companies are a minimum 1.5 to 2. So anyway, if you do that times the wages you get, I got $46 an hour on average for the average American worker using the lowest multiplier. If I'm off 50 hours, I would assume maybe this 50 hours continues for another month if we never use the counseling. That's $2,300 in workplace productivity savings so that one client talked to one counselor for 1 month. How much were all those cost savings for substance abuse and all those careful studies? $200 or $300 a month for a whole year? That's this total. For high intensity, very severe clinical cases, it's already this total, just for 1 month. So it's a whole different mind warp of thinking about the outcomes from mental health. Not so much the clinical savings, the healthcare utilization, but this. You can also ask people, what's your productivity like? What we've been talking about. You can also say, well, are you missing work? Are you showing up late? You're leaving early? Absenteeism. We typically find in this study, the difference is about 5.8 hours the previous month versus the month after EAP treatment. So divide that by the people who have the issues, you get roughly about a day of work or so. I looked at all these other studies that have asked about absence 30 days before, absence after using the EAP counseling. Assuming it's just 1 month, it's probably more than that. Average is half a day to 2 days or so. The math says it's about 1.3 days. It's about 10 hours of absence. Absence has the same value as productivity, right? They're not there. You're losing all that productivity. 100% of it's gone. Unless maybe some people help them, but then they're not doing their own work. So, here's the math story on presenteeism, absenteeism with workplace counseling. You can put in whatever numbers you want for what you pay your employees, but this math is going to be the same. The big savings are not in absence. People need their job. They're going to show up to work. They're going to work sick. They're going to work not very well. The question is, can you improve them when they're at work? That's the real question. And as a counselor, as a clinician, as a department, are you even measuring that? Or is it just some special pilot study? This is stuff we did 15 years ago at Optum every day, every customer, whether it was people going to a training, people calling a nurse for 10 minutes, people talking to a counselor, people using crisis services, people talking to managers, people using our website. We asked this every way we could. A lot of times there'd be no impact at all. So what? But at least we have data across our range of services about all these things. So you can tell this kind of story. Here's an academic review saying the same things. There's considerable agreement across studies. Presenteeism accounts for more aggregate productivity loss than absenteeism. See? Businesses are starting to pick up on all this data. Even if they don't read the special studies or go to those cool organizations I talked about, their writers are writing about it. This is last year, Benefits Magazine, huge magazine, goes to, I think, a huge number of human resource professionals. This is the cover story. Hidden cost, productivity, loss of mental health diagnosis. They specifically mentioned EAPs in here as a resource. So just as a big, and they cite all the same stats I was talking about. So they're trying to wake up HR people. So there's advances in measurement and employer data where they're getting at productivity and absence, not just other records. Unaddressed behavioral health issues can adversely affect employee health and work performance. The work burden, workplace burden. EAP counseling and other counseling that's not through the EAP, it's the same counselor, does restore work deficits most of the time, reducing presenteeism, and it does affect a small portion that have an absenteeism issue. Only about a third even have an absence issue to start with because they're working. But the burden and the work outcomes that change, relieving that burden, is overwhelmingly about productivity, not about absence. Many studies, previous decades, didn't even measure productivity. It's all absence. Productivity was a 0 data point. Didn't even measure it. It's too hard to measure. Can't do it. Well, now you can. So what are the questions on this type of topic? Just news to you, stuff you already know? Wait, sorry, you got to use the microphone.
So I was thinking about your definition of presenteeism.
Well, that's just that one guy's
I was
definition.
going
It's
to say,
pretty
because
broad.
it sounds like it's really actively disengaged. They're at work.
Yeah, engagement's the positive side of that same coin.
Yeah.
People call it engagement because they don't want to talk about addictions and depression. They talk about, I want an engaged workforce. What they're saying is, I don't want one that's all depressed. That's
But
using,
this sounds
that
like,
stuff.
it's funny because I was just thinking about my husband is having a big problem with his secretary at a big law firm. And, law firms are inherently negative. And I'm listening to him, and I said, do you realize how much time you're spending just telling me about this? And how much this is taking away from your
own work.
productivity at work? And he's like, no, I'm just telling you. But I'm like, no. This is costing you money.
Exactly.
And he hadn't even thought of it. And I think about just his situation with his secretary and multiply that by how many people are
in that
actually
firm.
there
Yeah.
and how much more money they would be making or more productive their time would be if they paid attention to this, because I don't think they have an EAP.
Well, they might not. A lot of smaller firms don't. Actually, that stable study I talked about said, well, what's the base rate normal level of disengagement? What's the base rate level of not being productive? And that huge study, that 770,000 people, they came up with a metric so that employers and HR people can say, well, the average loss of presenteeism is about anywhere from 3 to 7%. And it was highest for people with mental health and addiction self-report in their past. But they do have metrics to say, well, the average is, no one's 100% most of the time. But there's a little bit deficit. So it's really how do we rebound at least up to normal levels of slacking off or being stressed. But it's still a big gulf between the two. So a very good example of that. Thank you. Other questions? Can we get the mic, please? Or well, you go ahead, and then we'll do you next. You'll have to walk it over to him.
Curiosity of some of there's been discussion like Google and some other companies and just the environment they've created.
Yeah, a great work culture compared to many.
So differences of how that plays in with some of the EAP aspects.
Well, the best EAPs that have the highest utilization, 2 or 3 times these averages of 5%. A lot of EAPs are in the 15, 20% utilization range. They're at companies where senior leadership is very interested in being a healthy place to work. It's a high engagement culture. We want to attract talent. We want to keep talent. We have a very competitive marketplace. This is an organization where we think we're part of the problem. Our management style is working people too much. We admit that. We know that. We want to address it. And some management just won't admit to any of that. So we don't have stress problems. Employees do, but we don't. We're a great company. And so it kind of takes the more enlightened company to say, yes, I'm part of the problem. Therefore, I need to be part of the solution. We have to train people. We have to promote these services. So I think the biggest predictor of all of these outcomes is what this gentleman just said, is what's the culture and the leadership of the company. Because that's going to dictate if things are used or not. We actually did a study at Optum with that because we had so many hundreds and hundreds of customers. And we wanted to see, well, which customers are using the same phone lines, the same counselors, the same everything. And we showed that it was really the company culture and the account management. Would they let our account management come in and promote and use the service? Did they actually want to be engaged with the services? And some didn't. They just wanted to say they had it and, didn't want a lot of utilization. Because that meant they were a sick company, which is not true, but that's how they interpreted it. If they had high utilization, they thought that was bad. It's like, no, this is good utilization. You want this high. This is preventive services. This is productivity and improving services. So getting them to think that way is a challenge. Where's the other guy?
Okay,
He's got the mic.
So as a follow-up to the previous question, are employers allowed to mandate EAP services or strongly encourage, employees to seek out care?
No, they can have policies that relate to getting EAP involved if there is a workplace accident or there's a workplace trauma. They have to make services available, but people don't have to use them. But other than the workplace crisis event, and that's not even like a law or anything, it's more people have an HR policy about we want to make sure that you can have, that you have access to professional care. Well, the management referral is, again, it's a voluntary thing that the manager can do. It tends to be biggest in organizations that have very strong leadership about this is a good thing. We want people to use the services. We want to have this taken care of sooner before it's a big problem. For instance, if there's been a merger or a downsizing or companies are having a clash that they know is going to happen, they expect some of that. Some of the best utilization of the management consults actually come from high-use environments like mining, high-risk situations where they know they're going to have some problems because of the workforce. It also comes in places where there's a heavily unionized environment because a union wants to keep their union staff functioning, and they know a proportion of them have issues, and they want to help them. And so unionized areas have a lot of use where then people do know about it, but it's kind of protected within the union. Microphone, please. Oh, you've got the mic. Okay.
Yeah. A little bit of a takeoff of the previous comment and many of yours. There is this notion about strength-based workplaces that's been studied, quite a bit. Gallup's done the survey of over 2 million people worldwide, positive psychology, those kind of things. I've got a database of a couple of thousand human services employees that I've studied over the last 10 years, looking at risk and protective factors for burnout and compassion fatigue, for example. And I do think something that is interesting is that there are features of workplaces themselves that seem to be capable of kind of creating social inoculations against some of these kind of things as well. So I agree with your comment in those places that are healthy and engaging. They probably have a lower base rate of this in the first place. And when
they probably attract workers that are healthier, more interested in that too.
And things like retention, engagement, productivity, all that's higher in those kind of organizations. So I imagine that their base rate of these things is lower, but I also imagine the utilization of these things is higher because that's the health culture.
They get more okay to use it. Yeah, actually, my friend Joel Bennett runs a company that gets a lot of federal grants to study organizational health and wellness, and he's probably had 10, 15 years of showing that the health of the individuals at the company is highly correlated with the kind of management structure and leadership structure, and he goes in and then does trainings for leadership about, this is the path you need to go on and stuff, and specifically training managers how to, cope with some of these things in a more realistic way, which many are resistant to initially. So he does almost all of his training in groups. So it's not you, manager, have a problem. It's we're going to study this as a group. Everybody's mandated to take the training. Everybody has exposure to it. It's not penalizing or stigmatized. You kind of have to do the organizational work in a very different way than most clinicians are used to. Do a lot of group work, a lot of training work.
Most of these studies seem to be with huge organizations. And I'm sitting here thinking about the vast rural areas of small employers and wondering if they even know what their productivity costs are and what they might be losing. Is there any focus of emphasis on the smaller employers, that little bar that didn't have EAPs?
Well, Catherine, that's a really good question. And initially my data showed, maybe 1 in 4 small employers have an EAP. So most don't have it to start with. But the ones that do often may buy it through a consortium model, or they'll be part of getting the benefit through a community or other resource, or they just buy it. And typically the realization there is that they're actually more prone to productivity and absence issues because they have less staff to deal with it. And especially if it's a middle or higher level person at the company, it's even more severe impact if there is an issue. What they typically don't do is much of this measurement of using some of these productivity tools or absence tools. And often the director of the company is also the HR person. Once a week when they have to submit their payroll. And so they don't have a staff that goes to these meetings or uses these tools. Now, my goal has been to do the reverse of that and to train the EAP people to say, here's a 5-question set that gets at clinical efficacy, satisfaction, presenteeism, absence, and something else that's relevant to the customer. And give that to all of your customers, whether a small company or a big company. And so to at least come at it from the utilization side and then to offer those tools to companies to do that. Typically they don't have the staff to use it is the problem, to collect their own data on that. They would like to, but often they don't literally know how or have the staff. Okay, one more question on this before I move on to some last sections. Here, go ahead. Quick question.
So, as the provider, if a physician suicides, do you have a group or someone that's trained to go in and do that presentation?
Yeah, there's a whole specialty industry in EAP about crisis and suicide and domestic violence and really traumatic, very, very clinically specialized events. Often there's a nationwide network of people that EAPs hire kind of as a secondary service that they have on demand to go help, that night or the next day. And so that's often a secondary service that they buy to make sure it's done at really high quality. And they're usually not full-time EAP staff. They're a partner clinician expert who comes in. The big EAPs, national ones, have it. Yeah, they would be in what they call an affiliate specialty provider. And they see big value in that because, of course, it's a traumatic event. Thank you.
I was just wondering if you saw any difference in healthcare. We run a large healthcare facility. The costs are probably higher for absenteeism because we have to replace most of the FTEs when they're not there, call in unexpectedly. And it's high utilization of healthcare, low utilization of EAP. And we know that, but I wondered if you saw any other trends or differences.
Well, I'm not. That's kind of a difficult question to answer because there's so many factors we need to answer with that. But I think that would have to depend on more doing assessment of your situation. I imagine there's probably a lot more productivity losses that are actually going on than are being measured or realized. But people have to work because it's a shift work and they have to support the hospital. So they probably work anyway. The question is, how well are they working? Well, I'm going to move on to my last set of questions. So we have about 15 minutes left. Now I get a few points out before we have some final discussion. So there's obviously a lot of interest in these areas and some fine-tuning that could happen in organizations to deliver better workplace services or more organizational services, ideally. And one of the things that I've been trying to promote over the years is coming at it from not the clinician perspective, not from the patient perspective, but from the organizational perspective. Why do we have this at all? Why should we pay for this service, even though it's a generally very small fee? There's been, of course, a lot of interest in this academically over the years of individual organizations that have took the time and money to actually study it. You just had a question here about how is this going at my company. There have been some examples of, well, let's study this for a year or two at a company and try to measure everything we can and see what the real story is. And then they publish that or they present that at a conference or so forth. And they've actually had a whole special issue back in 1988 of many, many case studies of major providers of workplace services from the organization perspective or from the counseling company perspective. 8 major case studies of big companies, you'd recognize the names of them, appeared in 1992. SAMHSA did a big major grant-funded report with some major university professors, and so on down throughout the years. This is the typical finding. All of the published studies indicate EAPs are cost-effective. Largely because the cost is so tiny. The investment's very small, even though it's on a population-wide basis. The extent of improvement in outcome measures is limited by the kinds of clients seen, severity problems, and their work performance difficulties. So if you're seeing somebody for 1 or 2 sessions, maybe that's different from a more severe case. The outcome savings are much higher for the cases that involve addiction and depression and the more clinical severity issues, but then they take several years to find the cost effectiveness. But so this kind of language is pretty common in the field. A more recent study published 2011, my friend Rick Cernick in Canada did this study of 42 different published studies. Same finding. Stated as simply as possible, EAPs are effective, save organizations money. So this is professional academic literature saying this stuff. This isn't an EAP selling their services. I myself am fairly well known in the field about this business case ROI stuff. I get asked a lot about, well, where's all this evidence you talk about? If I go do a Psycholet search or a PubMed search, I find almost nothing. And that's true. Almost none of this research over the years has been funded by the things that fund you. Almost all of it's been funded by the individual employer or by the organization doing the services. Probably 1% of EAP services research has been funded by a grant. Still done by academics and professionals, but it's just not grant funded. So it doesn't show up in a lot of the basic journals. But what I've done is said, actually, there's a whole bunch of this stuff. And I wrote a little paper that's for free that lists 100 reports. Every report is itself a review of other studies. And if you want a lot of stuff, there are 5 books on this. If you want big government white papers, there's 20 of them. If you want to go read a scientific journal, I found 31 of them. If you want to read an employer guide that's written for business speak, there's 18 different guides. If you want to find different brief reports on this in trade journals, there's 26 of them. So these are my top 100 papers. So if people say, well, where's your data? I don't see the data. Well, you got to look in the right place. And almost all of these, I think 97 of them are free. So this is information. So what have I learned from all this stuff over the years? I've worked for corporations. I've worked for consultants. I've worked for the industry trade associations. I do stuff for clients. I think there's 4 stories to tell. I'm going to talk about each of those real briefly, and then we'll conclude today. But there are 4 different sort of value paths, a path to value. If you're trying to do this workplace service, what do you think will happen at the end of the year? What's your goal in doing this from a business perspective? Why should I have this? What should I see at the end of the year? Well, one is you can have primary value. You could also have Pareto value. You can also have productivity value, and you can have partnership. So I'm going to define those and give an example. That's one of my favorite pictures. I do photography. So primary value is essentially what they do in the entire medical field. I go to the ER, I go get a cholesterol test, I had a colonoscopy, that's worth $1,800. That's worth $1,800. By definition, because I provided the service and I'm an expert and I'm licensed and I'm a professional, the value is the price of delivery. Right? Counseling sessions cost $60 an hour, cost $100 an hour. Whatever that cost is the value. You go buy something at the hardware store, that's the value of what you pay for the service, pay for the product. Primary service delivery. No outcomes involved at all. The outcomes are inherent. Of course you're a professional, there's going to be outcomes. Just tell me what the price of it is, that's the value. So essentially it's a prepaid sort of valuing. So if I took the average utilization of an employee service for an average 1,000-person company, added up all the kinds of services that they provide in a year, put the street value for what those services cost, for this particular utilization level, this particular price, it's almost a break-even ROI just on, these are what the services are, this is what it costs to deliver them. If you were to go buy these somewhere else, this is what it costs. So things should roughly be break-even on this anyway, just as a business concept. So most other benefits use this model. They don't even involve outcomes. They just pay for the service. Pay for pharmacy, pay for ER visits, pay for whatever. That's the value. Well, Pareto value is a whole different ballgame. Completely opposite end of the spectrum. Very hard to define, very hard to show results. Well, what is Pareto? The answer is, who is Pareto? I can't speak Italian, but I wish I could. But his name is Vilfredo Pareto. More than 100 years ago, he talked about real estate in Italy and the observation that most of the really good land, in fact, most of the land in total, was owned by a few land barons. Probably still is. That skewed distribution is what he's become known for as an economist. Small group of things is related to the majority of events. In healthcare, this just says, if you can find the group of people that have substance abuse issues, that have depression, that have ongoing chronic issues, they're the expensive ones. You remember that really cool double chart that Darren showed, that the 1% slice of people was like half of the cost of American healthcare? That's the Pareto group. That's who they are. People get that. So it could collaboratively case manage them over time, get them into specialty treatment, help their relapse to be less often. There's a whole book written on this by some great researchers at Harvard. Work and health productivity. They talk all about Pareto cases. Page after page, study after study. So they reduce disability costs. They avoid further absence from work. They avoid employer turnover. And in the long run, they reduce medical costs, even though the treatment costs for psychiatry and counseling go way up for the first 3 to 5 years. Long-term payoff is very strong ROI. I found a number of studies in the EAP world that also do this. Only 3 of the 8 were actually published. Most were journal articles or white papers. All of them find a positive ROI for roughly the 10% of their caseload that had these serious issues. So the other 90% aren't even in this ROI analysis at all, just the severe cases. And they have a positive ROI just with that handful of cases. I do some math on that and make some guesstimates of, well, here's how many cases out of the 45 that got referred out. Here's how many of those actually used some care. I took roughly 2/3 of that. Here's some prices we would have for some of these things in claims costs or turnover over a couple of years. At least a 2-to-1. I'm not including multiple year outcomes. I'm not including accidents. I'm not including disability. There's a whole range of other stuff that probably doubles or triples this. The question is, this is a long-term, multi-year outcome. Most employers believe it, but it's hard to prove it to them. Unless they do their own study, and almost none of them in my 15 years have actually wanted to do a study of it with their own data. They all say, I want to do it. And I say, well, great, here's how we do it. They don't want to pay for it. They don't want to deny people services. They don't actually want to study it. But they believe the logic. So adverse effects on health and work performance can be improved, and there's these high-cost claimants and medical costs, disability, turnover, other areas that are high-cost, small number of people. So that's where you would like to get to. In reality, most EAPs in counseling don't do that. It's maybe 10% of their caseload. Maybe it's more of yours. That would be great. I wrote a whole paper on this for business people to read about it. It's going to be posted on the conference website. Productivity value. You can guess what I think about this one. This is that EAP counseling cases, by definition, with our data, most of the people who want to talk to a counselor have a work issue. 70%. It's a great place to start. It's not starting at 5 or 10% of the caseload. It's starting at 7 out of 10. Good place to start. Can they then improve presenteeism and absenteeism? These are a number of different studies that have actually studied this in clinical provider data from major EAPs and from some small EAPs, and have taken the time to publish their results. Some of them didn't do the investment side of it, so the ROI wasn't there, but the workplace outcomes were very strong. All of these showed a positive ROI, roughly 3 times the ROI value of the Pareto cases. Why is that ROI so much higher? How many cases are involved? A lot more cases. Probably 10 times the cases in many situations. So you have a smaller effect, but spread over a much bigger portion of your caseload. When I do the math on this using this tool I've developed, 36 out of the 45 cases are relevant. They're employees. Some are not employees. You average out the effects in those other studies, you saved about $100,000 in productivity for this 1,000-person group company. That ROI alone is 5 to 1. That does not include work life or legal or trainings or crisis or management or people who call up for financial advice or legal advice, the other 10 or 20, 30% of services. So strictly counseling. So again, this is probably higher. Well, for sure it's higher. So productivity path says you can find productivity savings that are higher than your clinical savings because they affect more people. You can find this usually in a 30-day measurement period as opposed to a 3 to 5 year measurement period for Pareto cases. And it affects most of the cases, and most people get better. In terms of the laws of numbers, those are 4 different numbers that are all on your side. High case rate, high base rate, high burden rate, high improvement rate, even though the value per outcome is pretty small. If you add it up to a whole month, it's a couple thousand a month. You say, I also wrote a paper on this that describes all this logic and these examples. That's also in your resources. The last area is very different, completely different animal. So far we've talking about just pay me for your services, primary transactional value. That's a pretty good story. Talked about the Pareto high cost, high severity cases. It's a more complex story, but it's certainly believable and funds a lot of programs. Talked about productivity, which is your work performance. But the way things are going is you have to do more than that to keep this kind of business and to be more effective and to find the cases you need. And that's you have to partner with people who aren't doing counseling. This is what employers are talking to Mercer Consulting about, talking to Aon Hewitt about, talking to Buck Consulting about. They're saying, I'm seeing all this super number data stuff, that all these costs are related, and that most of it's productivity or engagement related. And I see all these different programs that I'm paying doing different things, each telling me they have their own fantastic ROI. If I add up all these ROIs, my God, I'd be rich. So they don't believe everybody's ROI. And they shouldn't, because it's the same workforce. It's the same workforce, getting all these different pieces of services. So what we need to do is figure out how can we use the EAP counseling to also work with other areas. Now, this is not a radical concept, but it was sort of new a number of years ago. One of my colleagues, Pat Herlihy, did her dissertation on this. She surveyed companies around the United States. She found back in 1994 that of all the people that were selling EAP and counseling, 90% of those vendors sold just counseling. A couple years later, in 2002, we did a study for the EAP Field Association, surveyed all these vendors around the country in the U.S. It had grown to 33. Huge jump, tripling of integration of services, usually work-life or wellness. We wrote a whole book on this, 22 different chapters of different providers, different organizations, different research studies. Really cool book, a lot of information. Some were doing great at integration, some were so frustrated they didn't want to do it anymore. But kind of the whole story. We also did some other studies, most recently the vendor study I just talked about. Most recently, from 94 to 2011, 93% of vendors, small, medium, large, global EAP vendors, are selling more than just counseling. This is a radical change in 15 years. Radical change. So the purchaser, the workplace, the human resources, the medical director is saying, when I go to the EAP, I don't just go to the EAP. I go to all this stuff. Here's what they're also selling. 3/4 are also selling work-life, either as a direct service or a branded service. Half are also selling wellness. Trainings, prevention, health risk appraisals, all kinds of stuff related to wellness. Coaching is a big deal. And other specialty programs, mainly about Pareto cases. Am I managing addiction? Am I managing depression? Am I co-managing depression and diabetes? All these different co-management things. This is now the standard. And this data is 2 years old. Shocking change. So if you're not dealing with these other departments on a regular basis, most vendors now are asked to do monthly data sharing about their utilization, about their promotions, about their outcomes with these other vendors at big customers. Monthly data sharing, monthly account management meetings, maybe quarterly. But in a couple of years, it's going to be pretty standard that employers are asking you to share all this stuff. Here's what happens in the workplace. They do all kinds of stuff about, child care, elder care policy, work flexible time, paid time off, legal support, financial support, lots of things that aren't counseling. This is actually a really friendly front door into counseling. EAP and work life is a major area. We did a study once on this with Sandra Turner, used to be the president of the EAP Association. She works at Ernst & Young. They don't call their program an EAP. They call it EY Assist. Why? Because they want people to use it. People don't want to use counseling. It means I have a problem. They don't want to think themselves having a problem. So once they took the bother to use the same 2 national vendors, rebranding it under a common web portal, common marketing called EY Assist, the use of the EAP counseling with the same phone number, same staff, same vendor, went up about 60%. Identical service, just calling it something else. It also increased the other things. They also looked at account management, work life, what their corporate leadership was. They did a whole bunch of things as an organization to make this happen. Wellness is the other big area. Health risk screenings, physical fitness, weight loss, smoking, stress management, all kinds of things. There's a huge boom in all kinds of health coaching. That's me there trying to ride my bike, take some pictures. Got to get out from behind my computer. So, EAPs actually are also doing a lot of this. My friend Joel Bennett, who does all these organizational consulting things, we did a survey of the field. We found that roughly 1 in 4 to 40% of EAPs a couple of years ago were already screening all of their customers for these different issues. That's fantastic. I think it should be 100%, but it's a big amount they're already doing. So these are probably the third to a half that are also selling wellness services. There's a bunch of tools that have been academically developed with major grants from the U.S. government and other places that they give away or sell for very cheap, have training seminars you can go to like this. These are 9 items, 4 items. Any of these tools work pretty well. Pick one you like and start using it. This is the whole SBIRT movement. Screening, brief intervention, referral, and treatment. They use these kinds of tools. It's a whole website. You can go get this stuff for free. My friends wrote an article about why it affects EAP. The best actual prevention comes from the organizational level. If you can get an organization to buy into this productivity issue and believe it, then all kinds of other good things happen about trying to get in front of that productivity issue. One example of that was in our book in 2005. We did actually with the Minneapolis hospital system. You mentioned a health plan, a hospital. Fairview Health is a small health plan in Minneapolis. They did a multi-year intervention with all these different departments. Health risk appraisal, EAP, nurse line, lifestyle programs, disease management, and they focused on depression because all their data said that's a big cost driver. They got all these other outcome measures involved. Over a couple of years, they increased utilization to almost 50% of these different programs. It was about 12 to 15% before they did this study. So dramatic culture change at the company, of a company that sells healthcare, for Christ's sake. They should know all about this. Anyway, they ended up winning a C. Everett Koop National Health Award, and that business group, IHPM, gave them an award. And so doing this kind of work is possible. There is data that shows this works if companies want to put the time and effort into it. There are models you can follow to do it. Most just don't want to put the time into it. So if you look at ROI from an EAP perspective and you refer people to work life or wellness or disease management, you're just a minimal kind of handoff. and you add a little bit of value to those other cases that are much more expensive, you've got a break-even ROI just on that, just some handoff and referrals and co-managing. Very little time on the EAP actual operation. So the partnership path really is about working with other programs, other departments. The EAP field actually this year is coming out with a new certification for individuals called Certified Organizational Health Professional. It's for people in wellness, it's for people in HR, it's for people in occupational medicine, it's for people in EAP. And the idea is you come in the door knowing one of those 4 things, but you leave all the year or so of trainings knowing about the other 3 and about how they work and how to measure some of these things. And so it's training people to think a bit broader out of their silo and to get a professional certification for this. And so the field is recognizing this is now the standard, and we need to start training people on the standard. It's not just the best in practice companies. So, of course, I wrote some papers about this stuff with work-life people, with wellness directors. I did a big business case lit review in 2005 about this for the book. So huge amount of evidence this works. Well, let's just do the math kind of on the big picture here before we're done. Primary value is almost break even. The Pareto value, the small number of cases, in this case 6 out of 1,000 employees. The people that do productivity value go to counseling and are employees, 36 people, save 100,000. The partnership path, roughly 50 people, saves much less because the price per case is smaller. Average ROI is almost 9 to 1, with fairly low minimal 4.5% utilization. Primary path is break even. Pareto path, roughly 2 to 1. Productivity path is the big one, 5 to 1. Partnership, I'm guessing, is maybe 1 to 1. The partnership path, though, doesn't even need $1 to it. Because if you can get a company, an organization, to say you need to integrate, you need to work with all these programs, they already get the dollar side. They just want to see you start doing it. So most of the ROI studies on partnership, the employers don't want them. They say, I don't care. I want you to show me utilization. I want you to show me you're in the right cases in the right time and that they're clinically improving. And they switch the whole dynamic back to clinical issues. It's fascinating. The companies that have been at IHPM for 10 years, they don't even do ROI studies anymore. It's irrelevant. They do clinical effectiveness studies. Are you getting people the right level of care? It's fantastic. But it took a little progression of their thinking to get them there. They had to be sold on the value side first. So supporting behavioral health in EAP makes workplaces work better. ROI is one way to get people's attention. This picture is from a Workforce Magazine issue on ROI, and a lot of that issue talked about behavioral health. This is from people who are human resources people. That's the kind of audience we want hearing this stuff. So, I like information, as you can tell. The website has a number of things that Brandy's posted from my talk today. I wrote a book chapter for one of the occupational health textbooks, the article on presenteeism lit review, and some other lit reviews on work life and wellness, on the Pareto path, on productivity. And then, of course, I have a big reference list of any particular study that you're interested in. You can find the reference for it. And that's it for right now. Questions? Oh, here's the mic.
I resonate with everything you've said about presenteeism and absenteeism. But I was wondering about a third dimension, separation. That is often a very, very important indicator of distress.
Oh, yeah.
And it's not investigated. Now,
you mean the work turnover of an employee?
Yeah, an employee terminated. Yeah. And not being fired, terminated. Mm-hmm. And a number of years ago, I found myself in charge of a company that had over 10,000, almost 11,000 employees. And when a couple of my highest producers left the company, I got interested. So I visited them, and I found that this was a reaction to emotional distress, not their job, personal issues. And I helped get them into treatment. They came back and became, again, two of my most valuable employees. I followed up on this when I would have termination, self-termination. Yeah. I would visit them personally. And in about 3/4 of the cases, I would find that it was emotional distress. Yeah. I would get them into treatment. They'd come back to the company and be very valuable employees.
Continue to their...
Now, has there anything been done in that regard?
Well, that's a good question about termination, turnover, and the real causes of it, there's a whole huge literature in the HR field on termination and turnover. And overwhelmingly, most of the research about reasons for turnover is not related to competence or performance. It's not, I don't leave a job because I don't like it. And most of the other factors are not because I left for a better job. Most of it's because of these kind of personal stress issues, or they just don't like working there anymore. Their boss left, they don't like their new boss, they don't like their work team. That's the overwhelming predictor, actually. I just don't like my social environment at work anymore. It's not about money, and it's not about competence. And so then that becomes a question of really management and leadership at a company is how do we address this? How do we try to support people who are considering termination? The problem with this in the U.S. is that almost all workers are on an at-will employment contract. You can be let go for no reason. You're out the door, get a box and go. You're done by 5. It happens every day in America. In most other countries around the world, you can't fire people like that. Canada, you can't. They have a human rights charter. I'm serious. I mean, this is an almost unique American issue in many industries, and it's partly a reason why I think the decline of unions have caused a lot more workplace problems. People have a lot less rights in a company to be an employee. And so it creates a lot of management abuse situations where people don't take the time you have to find out why people left. And now the biggest ROI per event is really this turnover cost. And I have a whole turnover analysis model in my ROI research, but the problem is when I present it to employers, they don't believe it because it's so multi-determined. What is the reason you left? Unless it is something that they can track, like I had a substance abuse issue and it just got so bad that I finally got fired. I mean, they believe that. But usually it's much more complicated. And like you were saying, emotional issues, things that are more hard to really show up and measure. And so I think that's an area that's ripe for that. And another guy in Chicago has about 6 or 7 PhDs in psychiatrists, and all he does is support employers around disability and return to work for this turnover issue. It's his whole business because it's a very niche area that you need to really be more sophisticated about. Good comment. I mean, it should be on top of here, but I've had feedback about they just don't believe a very cursory treatment. You have to go into it really in depth. Another comment over here, please. Oh, she's same row.
Your trend data for growth of the movement from peer counseling into health and wellness areas is all. I was just stunned by that because it's almost a mirror of the increase in the concept of life coaching, health and wellness coaching in industries. In Las Vegas, Caesars Entertainment had a counseling center embedded in their corporate element, and people could come in confidentially and do it. They tried it for about 24 to 36 months. It was a massive failure. They turned that into a health and wellness center, added fitness, health, wellness, weight, and something else, I forget. And it just went gangbusters and massively improved productivity. To top that off, the same organizational structure that currently licenses nationally certified counselors, National Board of Certified Counselors, about a year ago began nationally certifying life coaches. It's the same organization, NBCC, and it's called Nationally Certified Coach. And I didn't know about this organization that you talked about in terms of wellness organizational stuff. That's a new certification. But I know that the life coaching thing has been huge in our state from the industry perspective.
Yeah. It's a way to resolve corporate issues about this area.
There was a capitated care provider in Las Vegas, I forget the name of it, and they provided behavioral health services to industries, and you had to go through them to get counseling services if you wanted to be funded by their insurance. They did away with that and went to the health and wellness coaching. And then the University of Nevada, Las Vegas instituted a master's degree program in life management, which is a feeder program to the certification.
Well, a whole other area of collaboration. I think we're out of time, so I'll let you say thank you for your time and interest.
Thank you, Mark.